Dear batch 22 students, we have already finished our basic periodontal tissue, the periodontal disease part, non-surgical management and surgical management. Today we will continue with periodontal maintenance therapy, which is phase 4 periodontal therapy. Starting with learning outcomes. The learning outcomes are classify post-treatment patients based on Merens classification, group the patients based on Merens classifications, design a flowchart for maintenance therapy, and practice a proper post-treatment management. So what is periodontal maintenance therapy? Periodontal maintenance therapy is a continuing periodic assessment of and prophylactic treatment of periodontal structures which permits early detection and treatment of a new and recurring diseases. So it is basically a continuous treatment which is done on a frequent interval of time, which will help us to identify new disease formation and prevent the disease progression by early detection of the disease. So the therapeutic intervention that augments debridement for a control of periodontal disease and maintenance of periodontal health. So the periodontal maintenance therapy is also called as supportive periodontal therapy, periodontal maintenance therapy, or periodontal recall maintenance therapy. Basically, it is a procedure which is performed at a selected intervals to assist the periodontitis patients in maintaining a good oral hygiene. So what is the goal of supportive periodontal therapy? So the therapeutic goal for a supportive periodontal therapy is to prevent or minimize the recurrence and progression of periodontal disease in patients who have been previously treated for periodontal disease, and to prevent or reduce the incidence of tooth loss by monitoring the dentition and any prosthetic replacement of the natural teeth if required, and to increase the probability of locating and treating in a timely manner of other diseases or conditions within the oral cavity which occurs within the time interval. So basically, the rationale of supportive periodontal therapy is frequent monitoring the patient so that the patient health is maintained, or the tooth loss, the progression to a disease to a tooth loss can be prevented or increased the time interval. Basically, it is the tooth loss is inversely proportional to the frequency of the supportive periodontal therapy. More frequently we review the patient and do a periodontal maintenance therapy, there will be decrease in the number of tooth we are going to lose over a period of time. So it is to reduce the risk of future attachment loss despite the plaque control. So what are all the components of supportive periodontal therapy? So during a supportive periodontal therapy, what are all the components? There are 3 components. Starts with examination part, treatment part, and patient appointment rescheduling. Basically, the examination part, which should include update of the medical and dental histories, examination of extraoral and intraoral soft tissue, examination of the dentition, periodontal evaluation. It is basically an update of whatever we have done in phase 1. So we have to re-evaluate and see whether any changes happened over a period of time during the interval. If it is a 3 months or 6 months interval, within that 6 months or 3 months interval, whether any changes have been happened. That is what we are going to do in the examination part, including the changes in the medical histories, any changes in the extraoral or intraoral soft tissues, any changes in the dentition, any changes in the periodontal values, any changes in radiographs, or assessment of the disease status and assessment of the patient personal oral hygiene. After we update all these histories and clinical examinations, we will do a treatment part, which is the second component of the supportive periodontal therapy. The treatment part should include a scaling, root planing, and If patient requires any behavioral modification, if patient requires any occlusal adjustments, you should do some occlusal adjustments. If patient requires any antimicrobial therapy, you have to introduce an antimicrobial therapy. If there is some recurrence of disease and requires surgical therapy, surgical therapy should be included. That is what the second component of the SPT, and followed by patient education of patient and rescheduling of appointments for the next visit, and updating or scheduling appointments for further management of the patient. That is what the components of supportive periodontal therapy. So it's basically comprises of update of the history part, examination part, and some treatment and scheduling of the appointment after the treatment. So what is the frequency of supportive periodontal therapy? So based on the type of the patient, the frequency of the supportive periodontal therapy will vary. If, for example, if a patient is presented with gingivitis, the normal frequency of supportive periodontal therapy should be once in 6 months time, biannual. If the patient is having a periodontal disease, then you have to reduce the interval, frequency of interval less than 6 months, most probably a 3 months interval. That will be the frequency of supportive therapy should be given for patients with gingivitis and patients with periodontitis. So what are the steps, or when we will start supportive periodontal therapy? Basically, the supportive periodontal therapy should be started after phase 1 therapy. So the re-evaluation of phase 1 should include phase 4 or maintenance therapy. So after every phase of periodontal management, you are going to go keep a maintenance phase. After phase 1 therapy, you are going to do a maintenance phase to re-evaluate the patients and educate the patient, and whether the patient can able to maintain the oral hygiene. Once the patient can able to follow the periodontal maintenance therapy, then we will do a surgical phase. Again, after surgical phase, we have to place the patient under maintenance therapy. Then we will do a restorative phase. After restorative phase, again we have to put the patient in the maintenance therapy. So it is a continuous process. So after each and every step of periodontal therapy, we are going to keep one maintenance phase. So all the other phases of periodontal therapy after phase 1 will be done during the maintenance phase. Right? So what is the duration of appointment for supportive periodontal therapy? So the duration of appointment is based on the number of teeth present, patient cooperation, patient's oral hygiene maintenance, the systemic health of the patient, the frequency, how we are going to call the patient, and the amount of instrumentation going to be done during the appointment, and the update in the history and changes in the sulcus depth will determine the duration of supportive periodontal therapy appointment. Normally, the supportive periodontal therapy appointment will be about an hour time. 1 hour of time, which includes an examination part 1, which accounts for 14 minutes, followed by a treatment part which accounts for 36 minutes, and finally the recall appointments or scheduling part, which is about 10 minutes time. So during the examination part, we have already discussed that the examination part includes patient greeting, is update in the medical history, update in the pathological examinations, extraoral, intraoral, soft tissue examinations, oral hygiene status, gingival changes, periodontal changes, changes in occlusions, dental caries, restorations, prosthetics. All these should be examined and updated within that 14 minutes period. Then followed by a treatment phase, which consists of scaling, root planing, polishing. If patient requires, you can give chemical irrigation and antibiotics. This will be comprised in part 2 or treatment part, which comprises of 36 minutes, and finally the update in the or cleanup and scheduling of appointment, which accounts for final 10 minutes, where you are going to write the report, discuss the report with the patient, schedule the next recall visit, or schedule the further treatment whatever required, or for example surgical therapy or restorative therapy or for prosthetic therapy, whatever therapy which is required in the next appointment should be scheduled, right? So what is the patient's conditions or situations and type of examinations based on the radiograph? What during a supportive periodontal therapy, when you will take a radiograph, and what is the type of radiograph and what is the duration of radiograph you are going to take. In a supportive periodontal therapy, if the patient is having a high risk of caries or high risk factors for caries, then a posterior bite wing examination should be done every 12 months to 18 months interval. If the patient is having a clinical caries and there is no high risk factors for caries formation, then you can extend the frequency of radiograph to 24 to 36 months, that is 2 years to 3 years once, not more frequently. If the patient is having a high risk patient, then your frequency of radiograph should be every year or every 1.5 years. If the patient is a periodontal disease patient and under good control, a periapical radiograph should be taken every 12 months to 14 months, and a full mouth series of radiographs should be taken once in 3 years to 5 years interval. Or if the patient having a history of periodontal disease with disease under control, you can extend or prolong the frequency of radiograph to up to 2 years or 5 years, up to 2 years to 5 years duration. If patient is having a periodontal disease and having a good control, then you have to take radiograph every year. If the patient had an history of periodontal treatment and still the patient is under good control, you can extend the frequency of radiograph to 2 years to 5 years. If the patient is having a dental implant, then the frequency of radiograph should be started with 6 months, 12 months and 36 months. The first 3 radiographs should be on 6 months, 12 months and 36th month after the prosthetic placement. Then every 36 months once we have to take a radiograph. Or transfer of periodontal or implant maintenance patients, you have to take a full mouth series in the current set if the current set is not available, and if a full mouth series has been taken within the 24 months period, then a radiograph for the site which is involved with disease. Basically, if the patient shows some disease activity during this maintenance period, then you have to take a radiograph for the site where there is a disease. And if there is no full mouth radiograph available, then you have to take a full mouth series of radiograph. If there is a full mouth series of radiograph available within the which was taken within the 24 months, then you can take only for the precise site where the disease is, right? So once we update the radiograph, we have to do a multi-level risk assessment also during our recall visit. A risk assessment and prognosis should be done during our recall visits or maintenance therapy. We already seen during our periodontal prognosis chapter, we have said that prognosis is not a static one. It is a dynamic process where it changes by time to time. Over a period, it can improve or it can get worsened based on the condition of the patient. So we have to do the risk assessment and prognosis on each and every visit when the patient comes for an periodontal maintenance therapy. So a continuous multi-level risk assessment should include subject risk assessment, tooth risk assessment and site risk assessment. So if the patient having a localized periodontal disease, then you have to evaluate the site for risk, whether the site can again go for a periodontal disease or not. That has to be done. The tooth level risk has to be assessed and subject level risk has to be assessed on every recall visits when the patient coming for a periodontal maintenance therapy, and the prognosis should be determined on every recall visits. Either it can improve from a poor prognosis to a better or a fair prognosis, or from a poor prognosis to a questionable prognosis if the patient cannot able to maintain. So this risk assessment and prognosis should be made on every recall visits. So what is the complaints of a patient for a supportive periodontal therapy? According to the data, only 16% of the patient will comply with supportive periodontal therapy. Only 16% of the patient will come to the clinic on time with proper maintenance. 49% of the patients will react erratically to supportive periodontal therapy. Either they will not maintain an appointment schedule, or they will not maintain the oral hygiene, or they will come whenever they want. That is, 49% of the patient will do that. 34% of the patient will never come back. They will come only when there is a problem. Once the problem is solved, they will not come back for a maintenance phase. They will come back only if there is a new problem arises. So this is the data which shows the complaints of the patient. So it is very difficult to get the patient to a complaints so that we can able to implement a proper periodontal maintenance therapy. So how to improve the complaints of the patient? To improve the complaints of the patient, simplify your treatment planning. So you educate the patient in a proper way and simplify the treatment so that the patient can understand and get knowledge about what is the importance of periodontal maintenance therapy. Accommodate the patient. So try to accommodate the patient need within your treatment protocol so that the patient can able to comply with the supportive periodontal therapy and patient can able to maintain and come back for your review. Remind the patient for every appointment. If the patient is going to have an appointment, call them and remind them that they are going to have an appointment on this day, so that it will help them in comply with the maintenance therapy. Keep the records of the complaints of the patient, whether the patient is coming on schedule with a proper maintenance. Keep a record of that. Inform the patient about the record. Provide a positive reinforcement to the patient and identify a potential non-compliance patient. If you think the patient will be non-compliance, then it is your duty to educate the patient in a positive way so that the patient can be modified into a compliant patient. So identification of failure cases. So how to identify a failure cases? Basically it is disease. When there is a recurrence of inflammation which is identified by gingival changes and bleeding of the sulcus during probing, or increase in the probing pocket depth leading to recurrence of pocket, or gradual increase in bone loss despite your treatment, or gradual increase in tooth mobility ascertained in clinical examination in spite of your treatment, then something wrong with your treatment. Your treatment is not following a proper recall intervals, or the treatment is not adequate. So you have to modify your treatment. So these things will help you in identifying a case which is failed during the periodontal maintenance therapy. And an ideal case, if after a phase 1 therapy or after any phase of periodontal treatment, during periodontal maintenance therapy, the patient should show some improvement in the disease. If there is no improvement and the case getting worsened, then the therapy should be modified according to the patient. So the basic idea of having a periodontal maintenance therapy is to identify such patients and modify our treatment so that we can bring back the patients to a better healthy state rather than getting to a worse condition. So what are all the symptoms and causes for recurrence of disease? What will be the symptoms and what will be the possible cause for recurrence of the disease? The symptoms, if there is an increased mobility, the possible cause may be increased inflammation. The patient may not be able to have a proper oral hygiene, or if you would have left some subgingival calculus or inadequate restorations or deterioration or poorly designed prosthesis, or patient is having a systemic disease which is modifying the host response to the plaque. These may be the cause for increased mobility or symptom, or this may be the cause for failure of your therapy. So you have to identify the cause and you have to treat the cause during your maintenance therapy. If the symptom is recession, then you have to think about, or the possible cause for recession will be a tooth abrasion or inadequate keratinized gingiva, or there will be a frenal pull, or patient is on an orthodontic treatment. This may be the cause for recession. Increase in mobility with no change in pocket depth or no change in radiographic changes, then you have to think about trauma from occlusion. The possible cause will be trauma from occlusion, either primary or secondary trauma from occlusion, or bruxism, or if there is a recent restoration, so you have to check for a high point in the restoration or a poorly designed prosthesis. If there is increase in pocket depth with no radiographic changes, then you have to the possible cause for the recurrence or disease progression may be due to poor oral hygiene or infrequent patient recall visits. There may be some subgingival calculus left out during the procedure, or maybe due to a failure in the new attachment surgery, or crack in the tooth, or poorly fitting dentures. These are the possible causes for pocket depth increase. Increase in pocket depth with increased radiographic bone loss, then the patient is not maintaining a proper oral hygiene, or your therapy is wrong. Either you have left out some subgingival calculus, or your treatment which is incomplete may cause to deepening of the pocket and bone loss. So your supportive periodontal therapy will help you in identify the possible cause, and with the help of the symptoms which the patient comes back to you during the supportive periodontal therapy, you can identify the possible cause and modify your treatment so that you can provide a better treatment for the patient. So coming on to Merin's classification. Based on all these factors, Merin classified patients into post-treatment patients into class A, B and C. For the first 1 year, he basically classified into patients with routine therapy and uneven full healing. You have to have a recall visit of 3 months. So based on the patient's condition, he scheduled appointment. What is the frequency of recall should be called for patients for a maintenance therapy based on the patient's characteristics. So within the first 1 year, he divided into 2 types of patients, either a routine patients or a difficult cases with complicated prosthesis and furcation involvement, poor crown to root ratio, or questionable patient cooperation. So for routine patients, the recall visit should be every 3 months. For difficult cases, the recall visit should be every 1 to 2 months interval. So this is for the first 1 year. After the first 1 year of continuous recall visits, the patients will be then classified into class A, B and C based on the patient's characteristic. If the patient having an excellent result, well maintained for the first 1 year, patient displays a good oral hygiene, minimal calculus, no occlusal problems, no complicated prosthesis, no remaining pockets and no teeth with bone loss or alveolar bone which is more than 50%, or should be called every 6 months to 1 year time interval. Class B patients are patients who are generally good result maintaining a reasonably well for the first 1 year, but patient having some problems like inconsistent or poor oral hygiene, heavy calculus formation, systemic disease, some remaining pocket, occlusal problems, complicated prosthesis, ongoing orthodontic treatment, recurrent dental caries, some teeth with less than 50% of bone support, smoking patients, positive female family history or genetic history, more than 20% of pocket bleeding on probing, then the patient should be recalled every 3 to 4 months for the rest of the time. For class C patients, basically these patients are generally poor results after periodontal therapy. After a periodontal therapy, the patients having a poor results or a severely negative factors from like inconsistent poor oral hygiene, heavy calculus formation, systemic diseases, many remaining pockets, occlusal problems, complicated prosthesis, recurrent dental caries, periodontal surgery indicated but cannot be performed due to patient's medical conditions, many teeth with less than 50% of alveolar bone support, conditions too far advanced to be improved by periodontal surgery, patient with chronic smoking habit, positive family history uh, or genetic history, or more than 20% of the pocket which bleeds on probing. Then these patients should be called every 1 to 3 months interval. So class C patients or more higher risk patients should be called more frequently compared to low risk patients. For example, gingivitis patients without any further inflammation or gingival disease, you can put the patient under a maintenance recall visit under class A, and you can call back the patient once in 6 months to 1 year time duration. So within that 6 months time duration, if you see any active disease or any new disease formation occurs and the patient cannot able to maintain oral hygiene, then you have to modify the class of patient to class B. If the patients after 6 months also the patient can able to maintain the status, then you have to recall the patient every 6 months once or once in 1 year. That depends on how good the patient maintaining the oral hygiene. So this classification is not fixed. Again, every recall visits, every maintenance visits, you have to again reassess the characteristics and you can modify the class of patient. So if you put the patient under class B, after 3 months interval, you see the patient maintenance is still more worse and more tooth involved with bone loss, then you have to modify the patient or move the patient to class C, where you are going to call back the patient, increase the frequency of callback to 1 to 3 months. Or for example, if you put the patient under class B for some reasons like inconsistent poor oral hygiene, after 3 months you see that the patient oral hygiene has been improved and patient can able to maintain over good oral hygiene, then you can move the patient to class A. That you can, the next maintenance appointment can be pushed to 6 months interval instead of every 3 months interval. So this also is not a static process, it is a dynamic classification. So every recall visit, based on the status during the recall visit, you can modify the patient's recall intervals either to class A or class B or class C, right? So who is going to treat the patient? So basically, if the patient having periodontitis, a mild to moderate periodontitis can be treated by a general dentist. If you see advanced periodontitis, then the treatment should be referred to specialist. So the schema for determining which practitioners should perform periodontal maintenance patient with different degree of periodontitis is basically mild to moderate can be treated with general dentistry or general practitioner rather than a specialist referral. If the patient is showing some periodontal disease which is moderate to advanced level of periodontal disease which cannot be managed with non-surgical periodontal procedures or with minor periodontal surgeries, then you have to refer the patient to a specialist for a proper periodontal surgery. So to summarize the supportive periodontal therapy, a successful supportive periodontal therapy is always with a periodontal maintenance therapy. A regular periodontal maintenance therapy should be required for a successful periodontal therapy. So periodontal maintenance therapy should always follow a active periodontal therapy, and you should make an interval of 3 months between appointments to make sure the patient is reviewed for new disease and any changes in the previously treated disease state. So supportive periodontal therapy basically is a continuous process. Once the patient come to you for the first visit, after the first visit, it is going to be lifelong procedure. You are going to put the patient on maintenance therapy and you are going to re-evaluate the patient for throughout the life of the patient based on the status, based on the Merins classification. If the patient falls under class A, then you have to call back the patient every 6 months throughout the life. So the patient should visit the dentist once in 6 months for a gingivitis patient. If it is a periodontitis patient, then the recall visit should be every 3 months once. Even though the patient doesn't require any active treatment, for example, the patient doesn't require any scaling or root planing even within the 3 months interval, but the 3 months interval should be maintained to reevaluate the periodontal status and check whether the periodontal status is stable. There is no new disease formation occurred within that 3 months interval. That is the reason we are going to keep the maintenance therapy. So you have to positively reinforce the patient that the patient should not think that I am not going to get any treatment done for the review visits, why I should go. You have to educate the patient the necessity for the recall visit. Even though they doesn't require any treatment, it is mandatory for them to come and show their status to a dentist so that the new or early disease detection can be done. If the patient doesn't follow that interval of recall visits, then we cannot able to identify or detect the disease activity in a early stage, and we cannot prevent the disease formation or prevent the progression of the disease. So a supportive periodontal therapy should be reinforced in every patient after phase 1 therapy to the end of their life. Till the end of their life, it should be continuous. It should be continued throughout their lifespan from phase 1. So supportive periodontal therapy is most important therapy and it should be followed based on the Merins classification. Either it is 6 months interval or 3 months interval. Okay, thank you.